All right, we've been through the what and the why of nystagmus. Now we get to the most critical part, the how. In this final explainer, we are going to take all of that theory and forge it into a powerful, practical tool you can use at the bedside with your very next dizzy patient.
So let's kick things off with a statement that really underscores the stakes here. A properly performed HINTS exam, which is just a series of bedside tests, is actually more sensitive for picking up a posterior fossa stroke in those crucial early hours than an MRI. Yeah, you heard that right. Your clinical skills can outperform our most advanced imaging. Let that sink in for a moment.
But, and this is a huge but, it's the whole reason we've built this series. This power tool only works when you apply it with almost surgical precision. It is not, I repeat, not a screening test for every single patient who feels dizzy. If you misapply it, you risk getting false reassurance, and that can lead to absolutely catastrophic outcomes. So today, our focus isn't just on what to do, but on who and when to do it.
So, where do we start? Our first job is to identify that high-stakes patient. We're talking about someone coming in with what we call an acute vestibular syndrome. You know the one. They have continuous vertigo, they're often nauseous, vomiting, and they can't walk straight. The whole challenge here, the diagnostic puzzle, is to tell the difference between a benign inner ear issue and a posterior circulation stroke, which can look exactly the same.
So how do we tackle this safely? Well, you need a system. A random, unstructured exam is, frankly, a recipe for disaster. You're guaranteed to miss the subtle but critical signs. The solution? A consistent, non-negotiable sequence, a foundation that you apply to every single dizzy patient, every single time, to make sure nothing slips through the cracks. So, what is this sequence? It's 6 steps. They are non-negotiable. First, you observe the eyes in primary gaze for a good 20 to 30 seconds. 2, you test their eccentric gaze. 3, you remove visual fixation. 4 is the head shake test. 5, you do your positional testing, like the Dix-Hallpike. And finally, number 6, you systematically document and classify everything you just saw. Remember, this isn't a buffet where you pick and choose, it's a protocol. Let's just zoom in on a step that honestly gets botched all the time, but it's absolutely critical: removing fixation. See, the brain is incredibly good at using visual targets to suppress nystagmus from the inner ear. To unmask it, you have to take that visual target away. And the only correct way to do this at the bedside without special goggles is to cover one eye and watch the other. Just asking the patient to close their eyes, totally useless. You can't see the very thing you're trying to look for. Okay, so you've done your foundational 6 steps. Now, if you find that your patient has continuous, spontaneous nystagmus, this is the moment. Now is the time to deploy your high-sensitivity tool, the HINTS exam. This is that test that outperforms an early MRI, but remember, only in this very specific clinical scenario. The HI in HINTS stands for the head impulse test. So what are you actually doing here? You're directly testing the integrity of their vestibulo-ocular reflex, or VOR. It's a quick, small, unpredictable head turn to see if their eyes can stay locked on a target. Now, the results of this test can feel a bit backwards at first, but they are so powerful. On the left, you're seeing an abnormal impulse. See how the eyes get dragged with the head, and then there's this quick snapback, a corrective saccade to find the target again? Now, paradoxically, this abnormal test is reassuring. It tells you the problem is likely peripheral in the inner ear. Now look to the right, a normal impulse, where the eyes stay perfectly glued to the target. In someone who is acutely dizzy, a normal head impulse is a massive red flag for a central cause, like a stroke. Next up, we've got the N for nystagmus type. Specifically, we're looking at its characteristics during that eccentric gaze test from our initial 6-step sequence. The big question is, does the pattern of the nystagmus change when the patient looks left versus when they look right? And here's the key distinction, the dead giveaway. A peripheral nystagmus is always direction fixed. It always beats in the same direction no matter where the patient is looking. Yeah, it might get a little stronger or weaker, but it never, ever reverses. A central nystagmus, on the other hand, is often direction changing. It beats to the right when they look right, and it beats to the left when they look left. If you see that, that is a clear, unambiguous sign of a central lesion. The final piece of our HINTS puzzle is TS, and that stands for Test of Skew. With this one, we're on the hunt for a vertical misalignment between the eyes. It can be super subtle, but it's a highly specific sign of a problem in the brainstem. So you test for this by covering one of the patient's eyes and then quickly uncovering it, and you're watching for any little vertical jump or correction. In a peripheral case, like you see on the left, the eyes stay perfectly aligned, no movement. But if you uncover an eye and you see it has to move up or down to realign with the other one, just like on the right, that's a positive skew, and that is a central sign, period. All right, everyone, I need you to listen very carefully. This right here is the single most important slide in this entire series. The HINTS exam is only valid, only useful in a patient who is actively dizzy with spontaneous nystagmus at the exact moment you are examining them. If their symptoms come and go, or if they've already resolved, HINTS does not apply. Using it in those situations is the single biggest pitfall that leads to misdiagnosis. Please burn this limitation into your memory.
Okay, so let's bring it all together now. After we've done our systematic exam, we've got to synthesize what we found into a coherent pattern. Does everything we're seeing fit with a peripheral cause, or are there red flags waving that point to something central? I want you to think of this table right here as your mental checklist, your at-a-glance comparison chart. So a peripheral pattern, it's going to be unidirectional and it's going to suppress when they focus on something. A central pattern, you're looking for that direction-changing nystagmus, or maybe a purely vertical one that absolutely does not suppress with fixation. And for positional testing, remember, peripheral causes like BPVP have that classic delay and they get tired out. Central causes don't. This little flowchart just perfectly captures that decision point when you're dealing with positional nystagmus. So you do a Dix-Hallpike, you see the nystagmus kick in, and you immediately have to ask 2 questions. 1, was there a delay before it started? And 2, does it get tired and go away with repetition? If you get a yes to both of those, you're almost certainly looking at BPPV. But if you get a no to either one, you have to start thinking about a central cause and dig a lot deeper. And all of this brings us to the final and, let's be honest, the most critical part. We don't do these fancy examinations just for academic interest, right? We do them to make a disposition decision. Your findings have to translate directly into a safe and effective plan of action. This flowchart right here, this is your action plan. The presence of any, and I mean any, single red flag, whether it's a pure downbeat nystagmus, a direction-changing pattern, or a failure to suppress with fixation, that is an immediate trigger. It means you need to get urgent neuroimaging, probably an MRI, you need to get a neurology consult, and you should probably be admitting the patient or activating your stroke pathway. No hesitation. And that brings our 3-part series to a close. We hope it reinforces our core message. The eyes truly do carry the diagnosis. By shifting from a disorganized, random approach to a systematic, hypothesis-driven examination, you can effectively triage for stroke right there at the bedside, and often with more precision than our initial imaging can provide. Thank you so much for joining us for the complete Nystagmus in the ED series. We really hope these explainers have given you some practical tools you can take straight to the bedside. To explore more topics on dizziness, vertigo, and imbalance, and to get access to more resources for clinicians and patients, please visit us at AustralianDizzinessClinics.com. If you found this valuable, we'd be so grateful if you'd subscribe and leave us a rating. Thanks for watching.